Well, we were discussing about the hyperkalemia and hypokalemia. Now today I will discuss with the hyperkalemia. A 60-year-old diabetic male patient, hypertensive, on angiotensin converting enzyme ACE inhibitors, was admitted with dizzy spells. जैसे कहता है चक्कर आ रहा है. On admission, his pulse was 60 per minute. BP was 110 over 70 millimeter mercury, and sensorium was normal. His blood biochemistry showed urea 90 milligram per deciliter, creatinine 2 milligram per deciliter, sodium 130 milligram per liter, and potassium 6.5 milligram per liter. So what will be the ECG changes? Tall peaked T waves with a shortened QT interval, progressive lengthening of the PR interval, and QRS duration. Disappearance of P waves, QRS widening, and a sine wave pattern, asystole, and a flat ECG. Step 1. Initiate the resuscitation. Patients with severe hyperkalemia need an urgent intravenous access and continuous ECG monitoring. They can have sudden bradycardiac arrest. ACLS protocol should be followed in these situations. Step 2. Assess the severity of hyperkalemia and urgency of correction. Hyperkalemia should be urgently managed in the following circumstances: ECG changes, muscle weakness or paralysis, rhabdomyolysis, that is, muscle cells are being destroyed, truss injury, tumor lysis syndrome, serum potassium more than 7, rapidly rising potassium above 5 milliequivalent per liter. Step 3. Rapidly correct the severe hyperkalemia. Intravenous calcium. Give calcium gluconate or calcium chloride 10 ml of 10% solution over 2 minutes under continuous ECG monitoring. This is important. Intravenous calcium works within minutes, but effect is short acting, that is 30 to 60 minutes. Calcium acts by directly antagonizing the membrane action of hyperkalemia and does not cause the lowering of serum potassium So it does not cause the lowering of serum potassium. Calcium chloride contains 3 times elemental calcium compared to calcium gluconate. That is very important to remember. And is preferred drug. This calcium chloride is a preferred drug. Intravenous calcium can be repeated after 5 minutes if ECG abnormalities persist. Concentrated calcium solution is tissue irritant and should be given in a large peripheral or central vein. Calcium should not be given in a bicarbonate containing solution to avoid precipitation of calcium carbonate. Calcium should be given cautiously as a slow infusion in patients on digitalis. Insulin with glucose. Give 10 units of regular bolus insulin intravenously along with 50 ml of 50% dextrose. Monitor the blood glucose every 30 minutes. In patients with baseline hyperglycemia above 250 mg per deciliter, only insulin can be given. So you do not include the glucose part because already the glucose is high, 250 mg. The effect of insulin begins within 10 minutes and lasts for 4 to 6 hours. Insulin and glucose lowers the serum potassium by driving the potassium inside the cells. This you should remember always. It decreases the serum potassium by 0.5 to 1.2 milliequivalent per liter. Beware of hypoglycemia in the renal failure cases. So the next video of this will be taken up in the next slide. Now what is